be started.
Confirmed, Chair, the live stream has been started.
I'd like to welcome those of you who are here in person and those of you who are joining us on Teams to this meeting of the Health and Wellbeing Board being held on Monday the 9th of December 2024. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. There are no members of the public present, so I do not have to ask for whether they wish to be photographed or not. Please can you ensure that mobile phones, laptops and other devices are turned to silent? For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you have finished speaking. For participants in attendance remotely, can I request that you use the raise hand feature within the system if you wish to contribute and to introduce yourself when called upon to do so. We now move to apologies for absence and any named substitutes. We have apologies from...
Thank you, Chair. Yes, we've had apologies from Kevin Crompton, the Herefordshire Safeguarding Adults Board Chair, and also we have a few board members that are unable to join us in person today but are in attendance remotely, those being John Butlin from Hereford and Worcester Fire and Rescue Service, Kate Carmichael, Director of Public Health from Herefordshire Council, and Superintendent Helen Wayne from West Mercia Police.
And can I also introduce Krishni Waring, who is attending for the first time today. Perhaps you'd like to introduce yourself, Krishni.
Thank you, Chair. Good afternoon, everybody. I'm Krishni Waring. I'm Chair of the Integrated Care Board for Herefordshire and Worcestershire. I'm delighted to be here today. I think Simon Trickett, our ICB CEO, is actually absent today, so I was quite keen to come in his place. Thank you.
Right, we now move on to name substitutes. Can I ask the clerk if we've got any name substitutes?
None in attendance, Chair.
Thank you. Any declarations of board members have any declarations of interest? No? Thank you. We move on to item 4, which is the minutes of the meeting of the 16th of September 2024, pages 9 to 16. The minutes of the meeting are included in the agenda. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as an accurate record? Yeah. Okay, thank you. We now move on to item 5, which is questions from members of the public. No questions have been received from members of the public. Item 6 is questions from councillors, and no questions have been received from councillors on this occasion. Item 7 is the update to the board on the Good Mental Wellbeing throughout Lifetime Implementation Plan on pages 17 to 42. The purpose of this is to provide an update on the progress of the implementation plan for the board's strategic priority of good mental wellbeing, which will throughout the document be stated as GMW, throughout lifetime, attached as Appendix 1, and it will be introduced by Kristen Pritchard, Public Health Lead on Mental Health. Okay, Kristen.
Thank you, Chair. So this is an update on the health and wellbeing strategy priority area of good mental wellbeing throughout the lifetime, and it's brought to the board with the following recommendations. Can I have the next slide, please? Thank you. So the recommendations are that the board considers the report, updated implementation plan and notes progress to date. The second recommendation is that the board considers how to ensure that all partnerships, partnership organisations are clearly cited on the implementation plan and expected outcomes, and references these across their own strategies and plans, both for adults, children and young people. Next slide, please. So there has been much good progress so far on the Good Mental Wellbeing Throughout Lifetime implementation plan. We have, since the launch of the priority areas, we have created the implementation plan, pulling together all of our partnership work to support the outcomes. The implementation plan is regularly reviewed and updated at the Adult Better Mental Health Partnership Board, which takes place every 6 weeks. In addition to this, we have developed an outcomes dashboard. The outcomes dashboard contains indicators which have been rigorously assessed and selected to monitor our impact on each of the outcomes. A review of the full dashboard will take place in January 2025 as part of the Adult Better Mental Health Partnership Board meeting. It is worth noting that many of the outcomes are longer term measures or annual data, as less data is available on a quarterly basis within the dashboard. Governance reporting arrangements have been put in place, and our first annual report of the implementation plan will be provided at Health and Wellbeing Board in June 2025. Next slide, please. So I've pulled out some key highlights from the implementation plan activity so far. There's a lot here that we could have included, but here are just some key highlights. So within Ambition 1, a PSHE toolkit has been created for primary schools to support well-being. We have now implemented the real-time suspected suicide surveillance system and created a suicide audit group to review this data as a partnership and monitor cases. In addition, we've delivered Solihull Parenting to support, which is a mix of online and face-to-face professional training to support well-being. In Ambition 2, we've commissioned a Children and Young People Quality of Life survey. This was delivered recently with the data soon to be available. As part of a physical activity intervention programme, we have supported people living with dementia and supporting them with their well-being. Next slide, please. Thank you. Within Ambition 3, a review of taught community has taken place, and we are working with our planning colleagues to create a tool which considers the impacts on communities with any planning applications to ensure we consider things like well-being. And within Ambition 4, we have provided investment into the Herefordshire Together programme, which has provided community projects with funds to increase community connection and support well-being. Thank you.
Before I open up to questions, there's just two observations I'd like to make. Under your Ambition 1, in the papers that were provided to us, one of the items was to deliver targeted physical activity, and you talk about the Stride Active programme. And I'd just like to comment that I have visited a number of activities that have been provided through the Stride Active organisation, and I'm witnessed some really good work that has been carried out by that programme. Really, really good work. I've actually witnessed young people who at the start of the programme have been very, have lacked confidence and been very loath to join in an activity, and by the end of the session have been up there climbing up doing rock walls and all sorts of things, and it's been a delight to see. So I'm really impressed with that. And the other thing I just wanted to raise was the £75,000 that you have given out for grants. Can you just give us a little bit of a flavour of the sort of things that they have been used for?
So there's a real mix of projects in the community. Mohammed, would you have a specific example that I can call on?
I don't recall on top of my head, but is the money that's given to Health Watch as part of the Herefordshire Together Fund? So maybe Christian might have some ideas. The types of project, yeah.
Yeah, so there were 12 projects, and some of them were things like Men's Shed in Bromyard, I think, and some gardening-based projects in different places, playgroups to bring young families, single mums with children together to do cooking and things like that. There was a funded project at the Hub in Ross, which was mainly around people with significant disadvantage. I'm racking my brains to think of any others off the top of my head, but yeah.
Does anybody in members of the board have any questions they want to ask on this? Hilary.
Thank you, Chair. I'm really impressed with the implementation plan, and clearly there's a lot of progress being made. I'd be really interested to see the outputs of the outcomes framework, because actually there's a lot of activity, but I guess it's the so what question, isn't it? And I get what's been said about some of those being very much longer term outcomes, and I wonder if there's some consideration that could be given to some more kind of proxy measures, so things that could be looked at on a shorter timescale, perhaps more qualitative in terms of feedback from people, that would just give us a sense of how well we're doing in terms of those longer term outcomes. Thank you, Chair.
Yeah, I agree, Hilary, absolutely. Kate.
Chair, that's very kind of you bringing me in. Yeah, I was going to talk about proxy measures, because we know if we look at kind of research, we can actually show things that actually contribute to the larger outcome. And so if we can actually sort of chunk it down, we can actually get some measures under that, which we know will contribute. The other thing I was thinking about is we've recently started meeting myself with the two chairs of the partnership boards to actually look at the outcomes, but also look at any gaps in our response and where we might want to actually think about developing new projects. So I think that's starting to go on, and Kristen mentioned that actually things are coming back to that board. But I think that kind of way of trying to look at it and saying we're doing some really good work now. I think some of the the Hereford to get the stuff and some of the priority work that we're doing really good. But where are the bits where we think, when we look at the outcomes, we look at some of the areas on fingertips and the outcomes areas that aren't so good? Where could we contribute? And I think that's the next stage in our thinking, Chair. And I hope you'd find that quite helpful.
Does anybody else have any questions? Steve?
Is the dementia work the work you're doing with Halo?
It is, yes.
I'd just like to say that's landed really well and really, really positive. And there's lots of really good feedback from carers as well as the participants with dementia. So it's a really excellent piece of work.
Jane?
Thank you. I won't repeat what others have said, but clearly lots of really good stuff going on. But it's both that understanding what difference it's going to make. So really looking forward to seeing the outcomes work when we've got that, and also just checking our ambition. Then I think once we've got that, are we being ambitious enough, or we might be being too ambitious? But I think we just need to check our level of ambition. And then I guess my question is around in here the needs assessment. I think you've now got that. So without blowing your things that you're going to tell us about when the needs assessment comes through, is there anything in that that's telling us that we're on the right track or the wrong track so far from what you've seen?
That's a great question. I think it's early days, and I think once the needs assessment is published, our plan is to have that review again of the implementation plan to make sure that we are covering everything that has come through the needs assessment. So I think it is a case of, yes, the ongoing review for now.
You've still got your hand up. Is that a new
Yes.
hand?
Is it me?
Yes.
I was just going to mention actually about the Halo stuff because that has been really inspiring. And of course, it won an award recently, so it shows just the reach of it, how much it's appreciated, and how we need to build on top of that work around prevention, around things like adult social care as well. So I just wanted to mention it won an award, folks. It was really good news. So,
David.
So yeah, in the action plan 2.2.1, we talk about neurodivergent children and young people. It's only the one place we talk about neurodivergency in this document, but at the Integrated Care Partnership Assembly a couple of weeks ago, the table I was on, Tina was here. Unfortunately, she's not here today, but talked a lot about how we need to come together as a system more effectively than we are at the moment to try and think about how we tackle neurodivergency differently. So I think we probably need to put a bit more focus on that going forward. We can tick that off as green. We know we've got a long waiting list for assessment. Once we've done assessments, we know we're going to have capacity shortages to provide care for people in these areas. So we need to think differently about that issue. I'd like to see that one included in future action, please.
Okay. Thank you, David.
It's a sort of point of detail actually, but I was just interested in again in the action plan. There's 1.3.3 talks about awareness of the issue of suicide, and actually there's some really good, very simple online training done by the Zero Suicide Alliance, which I've done myself. So I happen to know that it was really helpful for a lot of staff in the NHS around just understanding what you don't, not being an expert, but understanding how you can intervene. I just wondered if that was one of the resources that was thought of, as it's a freely available resource.
Yeah, so there has been quite a lot of recent and local suicide prevention work. So in the last 12 months, we've recruited a dedicated suicide prevention officer for Herefordshire, and part of the work she is doing is around training and awareness raising, and that has been really, really welcome here. And that's certainly one of the training offers that I've seen. Thank you.
I think also we're really pleased that we've been chosen to be involved with the Baton of Hope for 2025, and which will be on the 2nd, which we'll host on the 2nd of October, and we will do a lot of publicity hopefully around that to draw attention to suicide and the prevention of suicide. So I think that's a really good thing. I think particularly the fact that they've picked us out because they recognise that rural suicide is a big issue for the country and quite often is overlooked, and this has shown that they've taken on board the comments made in the past about it. The board considers the report updated implementation plan and notes progress to date, and that the board considers how to ensure that all partnership organisations are clearly cited on the implementation plan and expected outcomes, and references these across their own strategies and plans, both for adults, children and young people. Did we have a further recommendation?
Chair, just arising from points made during the conversation, I just wonder whether or not to inform the next update to the board, which seems to be in June 2025, that consideration be given to the presentation of the outputs of the outcomes framework, and also to neurodivergence within the ambitions.
Yep, that's fine. Do I have a proposal for that? David, Secretary? Hilary, thank you. All those in favour? Thank you. We now move on then to item 8, which is an update on the Inequalities Strategy 2023-26, which was found on pages 43 to 82. And the purpose of this report to update the Health and Wellbeing Board on the progress made towards reducing health inequalities in Herefordshire using the core 20+5 model. And it be introduced by Harpal. Thank you.
Thank you, Chair. Okay, so I wanted to talk to everyone today about the Health Inequalities Strategy, which is developed in 2023 and goes to 2026. The recommendations for the board is to note the work that's taken place in a relatively short time, and also continue to support the work going forward as well, and incorporating a core 20+5 approach into the health inequality strategy. And lastly, it will be to support the work to develop a revised action plan from the strategy, again incorporating that core 20+5 approach. I put a few slides together just to kind of go through the work that's taken place. So I won't go through too much what health inequalities are, but I think most of us are aware that they are unfair and avoidable differences within the population. And there we have the 4 dimensions of health inequalities. The main point in this slide is really the last point I would say is that action on health inequalities require improving the lives of those with the worst health outcomes and doing it fast. So identifying those people that are worse off and how can we make their life better in terms of health outcomes. So what's happening in Herefordshire in terms of health inequalities? This is an updated slide from the one I've been presenting. It might be quite difficult to see, but I can share it. I can share it afterwards. But essentially, it shows life expectancy. So this slide has just been developed in the last week, actually. So the top graph shows males born in Herefordshire and the life expectancy, and the line below that shows healthy life expectancy. So it's just been updated with the 2022 figures. As you can see, the purple line is above the black line, which is a national. The black line is a national average compared to the purple line, which is Herefordshire. So Herefordshire does have a longer life expectancy than national, and also does have a better healthy life expectancy as well compared to the national average. And the bottom graph there is females. One of the important things when we talk about health inequalities is really about reducing that gap. So life expectancy is how long someone's expected to live if they're born in a certain area. And healthy life expectancy is how long we expect someone to live in full health. And those remaining years would be not in full health. And it's really about reducing that window. And that's what we really want to do with the health inequalities, is reduce that kind of window with prevention. And some of those geographical differences, this has been well reported, and COVID was one of the things that really brought it to light. We could really see the difference in health inequalities and how they affect people. So people that were living in the most deprived areas of Herefordshire were 1.5 times more likely to die of COVID than those living in the least deprived. So that really highlighted the stark differences in health inequalities and the work that we should do. So what we're doing, I think it's been well covered that the health and wellbeing strategy covers those in the core priorities which we just talked about previously. The health inequality strategy identified 3 main core priorities, and that was rurally dispersed communities, travelling communities, including Gypsy, Roma travelling communities, and unregistered individuals. And they were the 3 kind of priorities that were highlighted in the health inequalities strategy. And one of the things to pick up here, which is in the report, was this health inequality strategy was being overseen by HIP, which is Herefordshire's Health Inequalities Personalisation and Prevention Board. And one of the things that was identified in HIP was that the strategy was fit for purpose, but members of the board felt the action plan could do with a revamp. The action plan had a lot of COVID recovery in it, and one of the things that we thought was that we could actually use core 20+5, which was mentioned in the strategy, to really use a more kind of practical approach to tackle health inequality. So that's one of the recommendations that we'll be making, is to to update the action plan but keeping the same strategy. So Core 20+5. So I'm hoping most of you have heard of Core 20+5, but I'll go through it. It's developed by NHS England, and its aim is to reduce healthcare inequalities, both at the national and system level. And we've really taken a real practical approach of how we can incorporate that into Herefordshire. We have two models actually. So you also have a children's Core 20+5, but the board, when we started incorporating Core 20+5 for adults, we thought it would be too overwhelming to actually incorporate the children's one into the dashboard as well. So what we've done is we just focus on adults and a few core indicators, and the children's one could be incorporated in the future. So what we've done was we took the Core 20+5 model. So it can be broken down to 3 areas. So you have your Core 20, which is your 20% most deprived population. So that can be thought of in 2 ways. So it could be your 20% most deprived in Herefordshire, or it could be the 20% most deprived in England, and what proportion of those live in Herefordshire. So it can be seen in 2 ways. We had our plus groups. So our plus groups were determined by using both the health and wellbeing strategy and the health inequality strategy. So those 5 core priorities that I mentioned earlier, they could be selected by each area. So the idea was that the Core 20+5 would be made into a dashboard, and each PCN would have their own plus groups. And then we have our 5 key clinical areas, from maternity, cancer diagnosis, severe mental illness, respiratory disease, and hypertension, and also smoking is added to that as well. So what we've done here was, this is actually on the back of the work that I done in Warwickshire County Council, and we identified a few key indicators for each of those areas to make it quite simple, but also these indicators were selected from QOF, which is the Quality Outcomes Framework which GPs use. And the idea being that if we can work closely with PCNs, it's also an incentive for them to improve on those indicators. So this was the theory of the Core 20+5 model and how we bring that to Herefordshire. We had help from Herefordshire General Practice to make this into a dashboard, which I'll give a quick demonstration on in a second. So it was developed into a Power BI dashboard using those indicators. And then we've done a series of training events and raising awareness with PCNs, Talk Community, Talk Wellbeing, lots of different partners on how to use the dashboard. And the idea being, there's lots of great work happening in PCNs, but there wasn't always that kind of rationale of why that work's happening. And now we were able to give PCNs that power of having the evidence base of why you should be targeting those groups. And kind of standardizing that kind of pattern as well. It also gave us the opportunity of being able to see across different PCNs what work's happening, what's not happening, identifying those gaps. Each public health lead, so we have 5 public health leads in our team, was assigned a PCN to help them support with that framework. So help them use the dashboard, help PCNs use the dashboard, also give them advice on frameworks for evaluations, checklists, lots of different tools were given. So for example, if a PCN identified that they had a specific need they had high levels of hypertension, they would use a checklist that we made. So they're checking NICE guidelines, what other kind of interventions are out there, are there ever any other PCNs doing any similar work? And the checklist kind of just helped us give a standardized approach to planning an intervention. It also enabled us to give an evaluation framework. Start thinking about what are you going to measure when you do that intervention, and that was really helpful in terms of when they come to kind of planning. And on the left there, it's quite small, but that was the original framework given for so the original action plan given to PCNs. So what PCNs had to do. The blue columns there was the rationale of why they picked that intervention. So they'd used the dashboard to identify which area they want to focus on, and now they gave a bit of a rationale a bit of evidence base on why they're doing that intervention. And then on the right was what intervention they're doing, target group, outcomes, and RAG rating. This has developed a bit more now because PCN's also reporting to ICBs, who also request an action, a health inequalities action plan. So we've put the two together now. So it's one action plan being reported to ICBs now, but it incorporates our work as well. So we've got our core 20+5 work in there as well. And the idea is that that action plan is fed into HIP, and we can have in HIP we can have a bit of governance. We can see what activity is happening, and that's reported upwards into 1HP. And that's the kind of cycle really of the work that's happened. And we are at that stage where the action plans have been collected. And the next step, one of the next steps will be kind of putting them in a single SharePoint so we can start reviewing them and seeing what work's happening. Before I go into the demonstration on the dashboard, I was wondering if there's any questions.
It's got a couple, really. I understand the strategy is to 23 to 26. It would be perhaps useful to put perhaps something with it when things have changed. So, for example, it talks about the introduction of the health and wellbeing strategy and going out to consultation. Of course, that's obviously happened, gone through, passed. It talks about faster share, and faster share doesn't exist anymore. It quotes, I think, the living wage at about £8 something, which is obviously significantly out of date now. So it might be useful to put some sort of amendments into that to show where we've got some progress. And also, just a minor, for me, a little confusion on the map that you've got with the trees and the leaves. I'm not sure what it means. So I'm assuming that the trees with green leaves are the very rural areas. And then what are yellow and the copper leaves, trees? And what looks like could be clover or could be another type of tree. I'm not sure what it means.
Yeah, I can see the confusion, Chair, around the trees. I'm not quite sure either. That was picked out from the health inequality strategy. So, but I can clarify that point for you.
Right, and the other thing, which is probably more of a, and it's a minor thing, but it puzzles me. So we talk about the fact that more deprived areas, you can expect life expectancy to be lower, particularly amongst males, but obviously also females. And then when you look at the map, if you take Leinster West and compare it with Webley being, I would imagine, to be the least deprived of the two areas, you have got a situation where the life expectancy of females in Webley is less than actually the life expectancy in the more deprived area of Leinster West. But with the males, the life expectancy is less in Leinster West than it is in Webley, which makes you think that if you're a female living in Leinster, in Webley, you should move to Leinster West, and if you're a male, you should move the other way round. But so it doesn't. It's a minor thing, and it may appear in other parts. I haven't looked at any of the other statistics, but it just doesn't fit with what we're actually saying in the document. So I'm a little bit nervous about this whole map, what it means. I think the green trees does mean rural areas, but I'm not quite sure what the yellow and copper ones are, because they actually are part of my ward, and I don't know what that means. And the other tree and a tractor with, I think that means rural, but I don't know. It's a weird thing, and perhaps if we don't know what it means, we probably shouldn't put it in, because then someone like me is going to ask the question and you're going to say, I don't know.
No, thank you, Chair. No, that's something that we can look at and revise. I guess my kind of only point would be that deprivation isn't the only indicator of life expectancy. It could be a number of other things as well, which are incorporated into that calculation. But that's something that I can look at and update as well for you.
Yeah,
So like
that would be helpful. But, and as I say, with regards to strategy, I accept the action plan does need to be updated regularly, but I do think we perhaps need to put an addendum or something to the strategy where things have changed significantly. But apart from that, I think the plan is good, and I think the action plan is good. Thank you.
Thank you, Chair. That's yeah, we'll take that on board for when we start developing the action plan.
Can I add a few additions, a question and maybe a clarification as well? So you talked about the HIP board. Just to add, there's also a system HIP board, Health Inequality Prevention Personalisation Care Board, which works across the ICS level as a whole. So the connections there are quite important. And at the next HIP board meeting, which is next week, every 2 months we do what we call a focus spotlight discussion on a particular topic. And this bi-month's topic is mental health and wellbeing and learning disabilities as well. So we can always bring some detail back to future health and wellbeing board about that. So that was number one. Number two, you talked about the ICB also asking for dashboards on some of these things. I think it's important to highlight that we're looking at the same stuff here. So from an ICB perspective, we put money into primary care through something called CIF, which is the Clinical Investment and Excellence Framework, which makes money available for primary care to develop bottom-up health inequality plans. So what they will be doing is developing their plans to feed into the local work here. So I wouldn't want people to go away with the impression it's a different piece of work that the ICB is asking to do. We put about £2 million into that area of work for local for PCNs. And the question I had was, that chart you presented at the beginning, which you said wasn't in the pack, was the new one. It was quite worrying, the trend for healthy life expectancy for males. Females largely staying above the national average, males still above the national average, but very much converging with the national average. Do we have any idea at this stage what might be driving that trend? And are we able to start to do something now that might begin to arrest that?
Thank you, David. So for healthy life expectancy, we don't have the calculations for the last 2 years, so we're just awaiting those based on the recent data. So those figures are for 2018 to 2020 for healthy life expectancy. So once we have those new figures, yeah, I think that would be definitely a point of discussion.
Okay, so it's quite significant. That's pre-COVID then, isn't it? And that really did shape how life expectancy and healthy life expectancy has gone. So I think we need to come back to that at a future point. Thank you.
Anybody else got any questions?
Can I just,
Yeah.
it was on that same point, because I was going to ask the question about the life expectancy and how recent that was, and clearly it's really old. But is it for the whole of 2020? So it would have included the first COVID year.
Yes, so it's the whole 2020. Yeah.
So we would expect there to be quite a big dip with that. And are you expecting this data to be more frequent in the future? Because looking at stuff that's 4 years out of date is not that helpful for us, really, is it?
Yes. So this data is being calculated for the JSNA. So I remember, Jane, you mentioned it at 1H strategy, and that's why I updated this slide. So that's why the life expectancy has been updated, but we're still awaiting the healthy life expectancy, but we should have that soon with the JSNA.
Lovely, thank you.
Anybody else got any questions? Oh, Kate.
Yeah, I was just coming in on the kind of life expectancy bit that people live, you know, obviously generally less in more deprived areas. I think the other one, it's sort of like healthy life expectancy, but disability-free life expectancy, which the amount of years you're likely to live in good health is actually quite important, because actually Harple talked about closing that gap, because what we really want is people to live quite well in their older ages and things like that. And Hereford, funny enough, does quite well for disability-free life expectancy, Chair. But but there will be differences within, different areas. So you might find it, for example, in the areas where people are living longer, they're still living more years in very poor health. Just a thought.
Thank you. Anybody else got any questions? No? Thank you, Harper. There's a lot of work gone into it, so thank you very much indeed. Yes, Harper.
Sorry, I just have an
Oh,
extra,
good, the
extra bit
dashboard.
to.
Sorry,
Yeah, I just
yep.
want to go through the dashboard,
Yep.
if that's okay, Chair. So this is the dashboard, which is available online now. So I'm just going to do a quick tutorial around how to use it and how it has been used by PCNs. So we have the indicators that we've been using here, and they're color coded towards which key clinical area it relates to. We have our core 20. So as I mentioned before, it can be used in those two ways. So if we're looking at Herefordshire alone, we can look at the 20% most deprived in Herefordshire registered to a GP. So this data is using GP records. So those people that are registered are only captured in this. So this gives us a breakdown on demographics, ethnicity, and also distribution by PCN. There's a couple of caveats with the dashboard that we're still working on. So one of them being bowel cancer screening is not quite working yet. Because it requires data linkage from a bowel cancer screening hub. So that's not quite working, and health check data isn't accurate. Health check data is done calculated on 5 years, and I think what we're showing here is 1 year. So that's the couple of caveats there. But what it does allow us to do here is give us a snapshot of comparing. Sorry, I just need to unclick that. Sorry, I'm just going to refresh that page one. Okay, now we're looking at the whole population. Before we were just looking at one practice. That's why it wasn't working. So this gives us a comparison between the least deprived and the most deprived. So we can have a quick snapshot of Herefordshire in terms of some of those indicators. So for example, if you look at cervical screening, in the least deprived quintile, we have an uptake of 72%. And in the most deprived, we have an uptake of 64%. So you can see there's a big difference between least and most deprived there. Also smoking, again, a big difference. So in the least deprived, in the most deprived, we have 18.5% smoking prevalence. And in the least deprived, we have just under 9%. So this does give us a snapshot of those inequalities. But obviously, there's a few caveats to this because it doesn't adjust for age, sex, and those kind of different demographics. So, for example, hypertension seems to be higher in those in least deprived areas, but that doesn't take into account age. So the general age is likely to be higher for those people living in the least deprived areas. So again, some caveats behind that, but gives us a quick snapshot of some of those key indicators and the differences between least and most deprived. The two most interesting. Yeah.
I think also on hypertension prevalence, it's probably reflected in the take up of blood pressure checks.
Yes, yeah.
So the to want to have a better phrase, the worried well would tend to have their blood pressure taken more frequently than people who are not accessing healthcare services. So therefore, it's not a surprise that some measures are higher in those least deprived areas.
Yeah, that's again another caveat in that data as well. I think the two most interesting tabs that I use in this dashboard are the bottom two. So if we go into, I'll go into 5 first. So these are the 5 key clinical areas that we discussed before. And what we can see here is if we are able to, look, it gives us a snapshot of the 5 different areas. But if I click onto this one, this kind of breaks it down into practices. And then we have a drop-down menu here, which is our indicators. So for this one, I'll stay with cervical screening for now. So this is cervical screening uptake. It gives us a snapshot of cervical screening uptake across the PCNs, and then for North, depending on which PCN you want to select on, you can get it by practice. However, there's an indicator that says no cervical screening, so this flips the question. So these are now women that have not had a cervical screen. So these are the people that do not attend. And this actually gives us some quite rich data, because now we can actually see the people that aren't attending and get that information in terms of demographics. So if I pick on one of the higher ones, so Kington. So we can see in Kington we have 562 women that haven't attended for their cervical screen. And we also get the breakdown in terms of deprivation. But we can go a little bit further, actually. So for those PCNs working in that area, if I click onto 5 now, we can go into a bit more data around that one PCN. So if I just click on North and West and Kington, the indicator is still there. Now I can see for that one practice which women haven't attended for their cervical screen, and we can see that there's you can do it by ethnicity, you can do it by age banding. Again, another caveat there: the age banding is incorrect there; it should be 25. But you can see it tends to be the younger women and the older category of women that haven't attended their cervical screen. So again, that could prompt a bit more learning into why that's happening, what are the potential barriers. But also we can see by ethnicity. So you could see, for example, for this cohort, Indian women, 27 women haven't attended for the cervical screen, and that counts for 84% of all Indian women registered at practice. So we can actually, there's a high percentage of Indian women that aren't attending their cervical screen. So it gives us a bit more information of how we can target interventions in terms of that. And again, we can do that across all different ethnicities here. And again, we have that for a range of different indicators. So not just cervical screening, but we can look at people that have severe mental illness. And they should have a care plan that's reviewed every 12 months. We can look at no care plans, so they haven't been reviewed for that last 12 months. And what are the demographics of those people? So that's the level of data that we can get from using this dashboard. And it's really been helpful in terms of planning interventions, having a bit more data and a bit more evidence before you go in and see an intervention. A couple of the things that we've been helping PCNs on is actually not just focusing on that one indicator, but also thinking about the wider determinants of health. So if those group of Indian women aren't attending their cervical screen, what else aren't they attending? Are their children having immunizations? So it's having that wider thinking, not just focusing on the one indicator that we picked on, but having that wider thinking. And that's been one of the things that we've been helping PCNs on. The second thing is partnership working. And that's something that we were really trying to encourage, and it's working really well, especially in terms of smoking. Talk community working really closely with PCNs on how we can target those pockets of the population that have higher prevalence. And I just wanted to end on one last thing, which was back to my slide set. Which is just a snippet of one of the PCNs and the work they're doing. So I won't go through the whole slide, but it just gives us that insight of how PCNs are using that data to plan their intervention. So at the top, we have a bit of the information that's taken from the action plan. So we get data around why they want to do an intervention. The prevalence of hypertension is high across a certain population. Cervical screen, like I went through, that's high in a certain population. Smoking, the prevalence isn't that high, but we want to target these people in more deprived areas, and then we get a bit more information on the work they're going to do with partners to tackle them, and that's the stage we're getting at now, of kind of developing those action plans and kind of having a sort of a single point to kind of review those action plans through HIP. And that's the kind of area we want to be in, and start reviewing those outcomes, measuring outcomes. So yeah, those are the next two steps, and I'll stop there.
Well, before I go to the board, I just want to say, Harpal, that is very impressive. I have to say, very impressive, and quite exciting that we are able to drill down to individual practices like that and work with them to improve the situation. So thank you, David.
Yeah, just to add, the next stage of development of that work really is to put the secondary care data set into it so we can see the whole NHS record for some of these individuals, because there's an interesting inverse relationship between some of that data and some of the data that Jane would see, for example, in ED. So people who are accessing less preventative healthcare are typically ending up having more urgent healthcare. So when we look at deprivation versus ED attendances, then people from more deprived areas tend to have more ED attendances, for example. They also tend to present later for cancer diagnosis, vaccinated less for COVID and flu. So there's a whole range of indicators that we need to look at to try and tackle this issue of health inequality. And if we can tackle all of those, then we can really make a difference in these areas.
And I think also, although it probably touches on the next item, some of the vaccinations that we talk about, particularly for older people, where we talk about encouraging older people to have shingles vaccinations and RSV vaccinations. I know that there are certain group practices that do not promote that at all, and you'll be able to see from your data those practices that are being very proactive, or those group practices that are being very, very proactive in that sort of side, and other practices that are not being so proactive in that area. And that will also be very helpful to sort of know where the good work is being done, and where perhaps some of the things are not being done as well as we would like them to be.
Thank you, Chair. And I just sort of expand on those points around additional sort of indicators in the future.
Yeah.
So that dashboard was developed as kind of just the main priorities. In the future, we do want to add more indicators. So, for example, in the hypertension one, we wanted to add something around physical activity or physical inactivity that we could highlight. And as I mentioned before, the children's core 20+5, there's some immunisation ones in there. We could expand to those different groups as well. The idea around this was baby steps, kind of training everyone to use the dashboard, and then when we add indicators, it won't be alien. People understand how to use it, and that's the stage we're getting at now.
Thank you. Kate.
Thank you, Chair. Yeah, I'm very excited by it, like everybody else is. I think it's amazing. And I think what's so brilliant is it actually allows us to segment the population into different cohorts. It allows us to start to look down and say, not just throw resources at the problem, but say, what do we need to do with this group of people? What do we need to do with that group of people? So our resource use gets better. So Harper knows how excited I am about this, but I think that sort of segmentation and that kind of trying to track down into people's lives and a kind of more hyper-local and a more cohort basis, that kind of population health management approach. I think this is the way forward, and I think we can do so much more good work by being that kind of targeted chair. So yeah, I think it's something we should do more of.
Thank you. Jane.
Again, I'm just really excited by this. It's the second time I've seen it, and I'm probably even more excited now than I was the first time. So a couple of points really. So one is that I think that that really strong link of the public health doctors and professionals into the PCNs is so important, and obviously the link into the broader talk communities and other services as well. So and it's just really great to see that. The other point then is around the seeing the output of it. Obviously, again, some of this is very long term, but one of the things we're really struggling with is this sort of over capacity in urgent care pathways. So the more that we can do here that reduces that urgent care demand, then it makes sense right across the whole pathway. But it's really good work. Well done. It's great.
Steve.
You touched on this, and perhaps this is the next phase in terms of why people aren't turning up for screening and things like that. have you considered reaching out to the VCS organisations and faith groups that work with those communities to help you get those messages across?
Thanks, Steve. Yes, so that will be up to the local PCN. So when they're planning their interventions, they're working closely with a public health lead. So we're able to provide them with, for example, what the latest evidence base says on those particular groups not attending their screen. It might not be relevant to this population, and that might warrant like a focus group or outreach work. But that is essentially the next stage. So understanding what those barriers are, for using that example, why those women aren't attending for their cervical screen. And then make an intervention based on that intelligence.
Kate.
I've seen that happen, Harper, so I think that's really good. When you actually take a group of women who perhaps are not coming forward, and I worked with a health work somewhere else in the country, and to look down into that group, we found a lot of older women weren't coming forward for their screen actually survive, and we actually discovered it was to do with sort of the menopause. It was to do with fears, uncomfortableness. We looked at the barriers. We actually had focus groups and surveys with the women, so we could actually identify what they could do. And of course, then we could have put practical things in place to reassure them, but also make sure any of their concerns were dealt with. So I think that's what's so good. You can actually titrate the response, can't you? And having seen it done, it does work. So yeah, I think it's a good way of actually trying to explore need and barriers in a more meaningful way. So yeah, thank you, Harper.
David.
Yeah, just thinking about things like uptake of vaccinations as well. You haven't mentioned the talk. I get it the wrong way around. Talk wellbeing, not talk community. The outreach service that goes out into the agricultural market, the village halls. One of the biggest impacts they've had is by providing vaccinations to people who wouldn't typically access a vaccination through another mechanism. And that's a really good platform for addressing some of these health inequalities. It might be useful having a presentation at a future meeting on the Talk Wellbeing service.
Yeah, do that.
And having a deep dive into some of the work they've been doing. Yeah. It will come to the HIP board next week in the system-wide HIP board on the work they've been doing, but it'd be interesting for the Health and Wellbeing board to hear that.
Anybody else? Halpal.
Sorry, can I just mention one last thing around the ICB? So we have worked, I know you mentioned earlier around the action plans. We worked really close with Selena and Roy from the ICB in terms of the Core 20+5. So it mirrors what the ICB are doing in terms of using the Core 20+5. We actually had Roy present at one of our workshops around ambassadors for Core 20+5 as well. So we were able to train some local people up to become health ambassadors. So it's worked really well.
Anybody else? No? Okay, we move then to the recommendations, which are that the Health and Wellbeing Board note the comprehensive and innovative programme of work which is underway to reducing health inequalities in Herefordshire. We continue to support a system approach to delivery of the strategic priorities identified in the Inequalities strategy and support work to develop a revised action plan to incorporate the Core 20+5 approach. And
yes, Chair, I think there's a couple of points about presentation, which was requesting that significant changes since the adoption of the strategy be highlighted, such as references to consultation on the health and wellbeing strategy and to Fattishire examples. I think you wanted a key perhaps on the tree icons on the presentation slide, health and wellbeing strategy. The health inequalities across Herefordshire agenda, page 73. Ms. Maffey mentioned about referencing connections to the work being undertaken across the system, integrated care system. As well. And then also in terms of requests for future updates, I think, again, Mr. Mahaffey mentioned the downward trend in healthy life expectancy for adult males as more data becomes available, and also a presentation on the work of Talk Wellbeing at an appropriate future meeting.
Yeah, that sounds fine. Any more recommendations you can think of that we have missed out? No? Can I have a proposer, please? I'll propose it. Seconder, David. Thank you. All those in favour? Thank you. We move on then to item 9, which is the Health Protection Assurance Forum Annual Report 2024, pages 83 to 142. The purpose of this report is to update the Health and Wellbeing Board on health protection systems, performance achievements and risks for 2024, as well as areas of development for 2025. And this will be introduced by Rob Davis, consultant in public health. Rob.
Thank you, Chair. I've prepared a few slides that allow me to share on the screen. Is that visible to the board?
It is.
Fantastic. So I wanted to briefly touch on a reminder of the role of the Health Protection Assurance Forum and how it relates to the Health and Wellbeing Board. A little outline of the annual report. It is quite a heavy data and surveillance report. So I'll highlight and bring out a few indicative areas of improvement and a few indicative areas of development. And a reminder of the asks is for the board to note the current health protection system assurance report, and a reminder of the opportunity for the board to seek further assurance in any of the areas from the subgroup, which meets quarterly, and the next group is January the 9th. So in terms of a reminder of the role of the Health Protection Assurance Forum, it is a direct subgroup of the Health and Wellbeing Board. It seeks to assure that satisfactory arrangements are in place to protect the residents of Herefordshire. So that's a combination of Environmental Health, NHS England, UK Health Security Agency, all having their different role. We've already talked about a few of them: screening, immunisations, as well as health protection, environmental health protection, and other system roles. So it's very much a collaborative effort. So I do want to thank my colleagues for their attendance throughout the year and for their individual contributions to this partner report. The structure of it, as is last time, it mirrors the different roles that each of the partners play. It covers antimicrobial resistance, adult and child immunisation programmes, the different variety of population health screening programmes, COVID-19, and an array of public health services, including sexual health, drug and alcohol, and an array of environmental hazards. So that's just to give you a sense of the breadth of the assurance arrangements and progress that we are meeting and discussing on a quarterly basis, and that we've attempted to sort of collate annually and present to the board on behalf of that group. In terms of things that have kind of popped out that are strong or improving areas for Herefordshire, we do particularly well in the human papillomavirus vaccination in 12 to 14-year-olds. We happen to be in the top 3 highest nationally, which is there's an element of not only sexually transmitted infection prevention, but also cancer prevention. Many board members will be aware that there was a lot of whooping cough cases this year that spread throughout the Midlands and nationally. We have a very high vaccination protection in children and babies. We're over 95%. That will inevitably, of course, us to have better outcomes than other areas. Similarly, given our older population, flu protection in terms of vaccination becomes very important. We have exceeded for a number of years and continue to do so the national target of vaccine uptake in over 65s, which is worthy of note. Similarly, 2024 was an important year for measles cases. There was a regional outbreak and a national outbreak with hundreds of cases. We have very few in Herefordshire, and again, that will be at least in some part due to our high measles, mumps and rubella prevention efforts and high uptake, which has been lower in the past. Illustrative examples of that: bowel cancer also pops up. Herefordshire is the maroon line on the top. You can see we mirror the National Improvement Programme but remain above. And on the right, we've got measles, mumps and rubella first dosage, the primary prevention of measles. We've been up in the heights of 96% in the recent past, and we're trying to get back up there. But you'll see the black line on the right is England's trajectory, which is generally down, and we are bucking that trend and making our way towards our aspiration of 95 or over through the collaborative efforts that Harper's touched on as well with PCNs and others. In terms of development areas, I'll kind of routine immunisations for children are kind of battened into 3 areas. Kind of got a bronze, silver, gold. Gold would be cover over 95%. Silver would be anywhere between 90 and 95. A lot of our activity is there. And bronze would be less than 90. So we do have 2 booster vaccines in that bronze category. We've got specific ambitions to bring up that include preschool boosters. So we've got a programme of work related to that. Others have already been mentioned actually, or some of the national screening programmes are yet to bounce back after COVID or are in long-term decline. So with national colleagues and with local colleagues, we need to work out whether we really understand the issues of those locally and nationally and see what we can do to start turning those around. I think I've got some illustrated graphs for cervical cancer screening. There's 2 different age categories for screening. On the left, it's the 25 to 49-year-olds. You can see that gradual decline. The Herefordshire on the top graph, top line, and England on the bottom line.
It is, isn't it?
And you see the same pattern for Herefordshire and England on the right. Those are just some of the snippets of intelligence that we're looking at on behalf of this subgroup that inform our future activity and is worth flagging to the board. So a reminder of the role of the group, a few indicative areas. The detail is obviously in the annual report, and a reminder of the hours to note the information in that report and an opportunity to seek further assurance from the group at any point. Thank you, Chair.
Thank you. That's very, very useful. Before I pass over to the board, just one observation that I saw was when you were talking about some of the work regarding some of the achievements and risks, and particularly around drug addiction, etc. And you make reference to the fact that the consequences of the decision in 2022 to ban the cultivation of opium poppy in Afghanistan has resulted in synthetic opioids being produced to meet demands, and the risks of these drugs because of their varying strengths, etc., and resulting overdoses. And I suspect that the average person in the street would have seen the decision that was taken in 2022 to stop the production in Afghanistan as being a positive move, and I expect we all did, but the consequences of that has actually proved that we've got a greater risk now of drugs that are going to cause greater harm than we did before, and that is probably definitely not what we would have wanted. So it's an interesting comment that's been put into the report. Thank you.
Hi Rob, do you mind if I comment to that? I guess commissioning Turning Point and also representing on the Combating Drugs Partnership, both locally and regionally. We've been asked to put a plan together which came off the back of Project Mabel, which was the evaluation of how the contaminated opioids was dealt with in Birmingham. So each region has been asked to develop a plan, and we've just put ours together, and we'll be presenting at local CDP and regional CDP on how a board would assemble should contaminated drugs come onto into Herefordshire. But we have systems in place which weren't a year ago, including something called ELDIS, which is a local drug information system. So we can ping messages across different partners rapidly now, and also a drug-related death panel where we review every death related to drugs in Herefordshire. So there's 2 new systems in place, and additionally that plan for reassurance.
Right, thanks. So the cervical screening one's really interesting, isn't it? Because it's a trend that's been going on for a really long time. And so I was wondering, Kate, from your experience elsewhere, and you said you've done work on this, What's driving that lack of take-up for all women, actually, cervical screening? Because this isn't a COVID effect. This, you know, we've gone from a high in 2010, and both have lost about 10%.
Yeah, I know. You do seem to find that pattern of the younger women and the older women. What we explored was the older women. Actually, we did some work with them, with some general practitioners, and they did some work with us, and we did focus groups and stuff to find out what were the barriers. The barriers were, I don't know if we've been to in many cities, but they were very practical barriers of women going through the menopause that you might think, actually, because the whole procedure when you're somebody who is a bit older can be a bit more painful and a bit more troublesome, and nobody had thought to say, well, how do we make that better? So the GP started to offer things like HRT, actually, before that happened, and that really helped. And then they actually allowed them to book in and come in a sort of more considered way, have some time to discuss it. And also they also put in some work around menopause support, actually. So off the back of that, they actually started doing more work with some of the symptoms that affect older women. And that really helped, because we were working with a business and women group who were actually trying to get older women to go back to the workforce. And some of those barriers, and you can imagine what the barriers were: menopause, caring, a whole range of things. So we started to do we started to link up that thing. And actually, I think the ICS there got to become a menopause-friendly organisation. It won an award in the end of it. But I think it was that simple thing of identifying the women and then saying, what's the problem?
I get that, Kate, but the issue is, I mean, there were as many menopausal women in 2010 as there were in 2023.
Oh, yeah.
So the fact that it's just been on a downward trajectory where lots of other indicators have stayed flat or have gone up, it just feels like there's something. But you know, all we're doing is following exactly the national trend, and so there feels something very odd going on.
In different groups, that's the thing. I mean, it's hard to mention, actually. Maybe in ethnic minority women, you'll find it much harder. Again, when I've worked in other places where I worked with ethnic minority ladies, they actually, it was the problems of going into a surgery with a man, not getting sort of female support, things like that, which was really problematic. We had to do some work around that to actually bring, because unfortunately, in this town I worked in, all the GPs were male, and the nurses hadn't been trained. So we actually did some work. It was years ago, but we actually did some of that work. I think that there's nothing better than actually sitting down and actually talking to the groups and trying to understand the barriers, the obstacles, and then actually how to make it easy. Some of it can just time. You know, I can't get there because I have to look after my mother, I have to look after my children, I have to do that. And you know, I think over the COVID period, we saw a great burden placed upon women who were doing work in educating their children, a whole range of things. And I suspect that's affected them in lots of lots of ways. So I think that they're probably a group that we are seeing quite still a lot of impact from COVID on, particularly a certain group of women who have all these other family responsibilities. There's no, what I'm going to say, there's no easy answer to it. That's it. But we need to explore it and think, where can we actually think about where it is and how can we intervene in that to make it easier, and making it easier for people to get screened closer to home and things like that. You know, I know GPs are closer, but maybe there's other things we can do. You know, for more vulnerable women.
Thank you. And then my second question was around breast cancer screening, and is it because we're still catching up that it's lower now and it's a backlog issue, or is it again that women aren't coming forward for it in the way that they used to? So do we know what the issue is with breast cancer screening?
I think I might be able to help.
Oh, hi Rob.
Yeah, I think that is one of the ones where we've got evidence where we were high and then we dipped in COVID and we're on the way back up to pre-COVID levels. So I think that's a backlog working through back to normal. Yeah.
Great.
We've got evidence to suggest that.
Sorry. I just wanted to make a point on the cervical screening. I have a background in commissioning screening programs in the NHS a while ago, and one of the things that we saw in 2009 was the death of Jade Goody, and we that elevated the amount of people coming forward for their cervical screen, and I think there was some evidence around the cycles as well. So those women that went through that period when Jade Goody died, every 3 years for the younger women, and every 5 years, those you get a increase in uptake again, because that's been a lasting effect from the legacy of that. That's just one of the points.
Before I bring Christine, I think you actually not hit the nail on the head, but you're absolutely right. Jay Goody, I remember that well, and the uptake that there was then. There was a significant uptake on, I think, bowel cancer testing when the young lady that died, or rather when they started the podcast around that. There's been an uptake with regards to prostate cancer when various male celebrities have come forward and spoke about their issues regarding prostate cancer. And obviously we all know that there's been a lot of publicity around MND, and that tends to mean people come forward and see whether it's been tested for them. So I think there is, rightly or wrongly, we are in an age where an awful lot of social media stuff is out there that does influence the way that people lead their lives and the things that they feel to be important in their lives. And it sounds awful, but probably to get these figures up again, you need somebody of a high profile that is prepared to promote it, that will actually raise the numbers. Christine.
Thank you. And it was about these two development areas that Rob highlighted in his report: breast cancer screening not recovering, and also cervical screening declining. And it's interesting because obviously in the health and equalities space, early cancer intervention is highlighted as a really important area. I was just going to mention that the Chief Executive of NHS England in November announced that there were going to be, through the NHS app, a strengthening of it's called Ping and Book, which is sort of use of the NHS app to really try and drive greater uptake. And the stat I came across was that nationally, 35% of women have not taken up their breast screen. That's a lot, actually, if you think about it. 35% of women not taking up their breast screen. So the use of the NHS app in trying to encouraging people to book, to get a message, a notification that they need to book, and make it easy to book, is one of the things that NHS England is doing. But I'm really conscious that we've also said in our health inequality strategy that one of the issues we potentially have, and other systems do too, is that the difficulty of digital usage and take up. So it was just something about where are we and how can we encourage more take up of the NHS app, because that might be, I think Harple's database and the localised examples that we saw earlier will be really important, but also things like driving the use of the NHS app might actually be one of the ways in which we can help maybe younger women particularly take these things up. So I just wondered if that's something we need to explore. I know we've talked about it at the Integrated Care Board, about encouraging all our employees, for example, to register and make sure they've got access to the app, but just wondered if that's been thought of at all.
Thank you. It's not something I've seen in any of the action plans at the moment, so we'll bring it to attention, especially for those lower cohorts that we mentioned, because we can break down by age as well. We can see, I guess the lower age cohorts would definitely be more responsive in terms of apps. But something I'll take back.
Before I come to Kate, just a question really. The breast screening van, how rural does it go? I mean, I know for the north it goes to Leominster, or it did when I personally was using it. Does it go any further out than that? Because that could be another barrier, because if you don't have if you don't have access to a car and you live in a ward like mine, you would not be able to get to Leominster without your partner, who may have the car, being able to take you. Rob?
Sorry, Chair. Yeah, I would have to look into that, to be honest. I think just to loop back, because there's some useful suggestions in the room. What we do have is we're trying, because some of these are national issues, we do have the regional NHS England member on our protection board. So one of the angles we're trying to do is learn what we can from the feedback from national issues of why people aren't. And then if we've already got those solutions in place, but we're still declining, then I think we will need to be in a position of going a bit more hyper-local. That's where that population health dashboard that Harpole is referring to could help us. We're probably not at that point right now, but we could certainly incorporate the suggestions that's been made here, and with a focus on breast cancer and cervical at the next forum, to see if we are doing enough with our local data to understand issues and whether that might steer us in a better direction. I don't have a direct answer to the rural screening question. I would have to follow up outside the meeting unless anyone else knows in.
David?
So I don't know a lot about it, but I do know that the lorry tends to go to population centres where people gravitate. So
Yeah.
I know it's over the border, but it would go to Tenbury, for example, and it would be in the community
That would
hospital car
still
park.
be, that would
still be 5-6 miles away from.
Yeah. So
I mean, I know I'm 6-7 miles from Leominster, and similar from Tenbury, and without a car, I would not be able to access the service.
And there are some services that we can make hypermobile. So, for example, diabetic eye screening can be very mobile. There are other services where it's a big lorry that can't just go and spend the day in a place where it might get one person going to visit it. So it's that balance between access and impact that we've got. I mean, I've hesitated to add, this is an NHS England commission service, not an ICB commission service. But at some point in the future, no doubt it will be delegated to us as an ICB level, and then we can start to look at some of these issues in more detail.
I've just Googled it, and it's Ross, Leominster, Bromyard, Kington and Hereford. Okay.
Yeah, that will be an issue, particularly for people in areas of deprivation. It will be an issue. But it will be an issue for people who don't drive. Eight.
Sorry, I didn't quite catch that. Yeah, no, thank you. I was going to talk about the ping and book thing actually, because that's trying to fully digitalise things and make it easy and get reminders to people's phones, because most people own a phone, but that doesn't solve the problem of access. Sometimes doesn't really, or having the time. Then there has been a survey which I'm happy to share with people that was done in September, looking at some of these things, and 73% of women came out with they would like a self-testing kit for HPV. Actually, and they are on sale and they can be given, and it might help. So that's one thing that people came out with, saying if we could test at home, we'd do it. So maybe there's something about that. The other stuff that I just went through the survey just quickly, it talked about wanting the same sex, ease of travelling, wider choice of appointment times, problems with Asian population, some Asian women. But the self-screening came out as, I think, a particularly interesting one, and I'm happy to share that that survey with people if people are interested to have a good look at it.
Thank you, Kate. No? Right. Thank you very much. Then we move to the recommendations, which are that the Health and Wellbeing Board note the health and protection system performance achievements and risks for 2024, as well as areas of focus for 2025, and that the Health and Wellbeing Board seek any further assurance via the Health Protection Assurance Forum. Was there anything else, Ben?
I don't think it's a specific recommendation. Clearly, the matters around promoting screening and the ping and book system as part of the NHS app will be referenced in the minutes. I'm sure officers will take that up through the appropriate forum.
Thank you. Okay. Can I have a proposal to those Hilary, seconder? No, Christine. Thank you. We move on to item 10, which is the work programme, which is to consider the work programme for the board. The updated Health and Wellbeing Board forward plan 24-25 and 25-26 has been circulated in the agenda for review by the board. Is everybody happy with that? Yes? No. Hilary's pulling a face.
Just seems a lot of items on the next meeting agenda. That was all I was.
I think
saying.
there's a lot of items on the next meeting.
But they may well.
They may be, it may be little, but they look big.
Yes, Chair. I mean, a couple of those, as you'll see on page 144, a bit moved from this month to next. But there may be some elements that that perhaps through the briefing we can refine that down.
Yeah, I think we will bring them some of those down because it does look rather a lot to me as well. And then we haven't got many at the present moment on the June meeting, so it does seem as though it's a bit of an overload. Okay.
The point prevalence audit findings might be better placed in the workshop discussion in February rather than the public board item. There's plenty of other places where those findings have been reported to public board at the ICB and various other formats, but a conversation in February might be a better place to hold those. I don't know, Jane, what do you think? Yeah.
I think the ones that we probably moved, we ought to try and get in. Otherwise, we'll just keep moving them on and on and on, and I don't think that's right. But yeah, we'll take a look at that. Absolutely. Thank you. Right. Okay. So the date of the next meeting is Monday, the 17th of March, at 2 o'clock, and the date of the next workshop session for board members is Monday, the 3rd of February. At 2 p.m. and based on the discussions we held at the previous workshop, I'd be really grateful if as many of you as possible could be present at that meeting because I think it's a very important meeting. All right, thank you very much indeed for coming up today. Thank you. Yep.
What's on the agenda for the February workshop?
It's to look at the health and wellbeing strategy action plan.
Okay.
Yeah.
The outcome dashboard. Basically for the best start in life and the good mental well-being.
Okay. It's as a result of the last workshop.
Yeah.
Okay. Thank you very much indeed.